that, we were in the way of these Israeli missiles. They were not targeted at us, just that we happened to be in their way. And my flight got, rerouted to Vienna. Good to see you all here, and welcome to the masterclass. This masterclass, as Pranay rightly said, focuses mainly on a niche subject, something as niche as cardiogenic shock. Clearly, it's a cardiologist topic because most of this essentially gets dealt with in coronary care units. Having said that, it's clearly, the cardiologists as well as other specialists are now realizing that however good a job they do in the cath lab in the acute circumstances, they lose a lot of their patients to multi-organ failure. And that's clearly after doing high-risk PCIs and doing, some of the complex PCIs, they still end up losing the patient. So a change in approach is what is actually needed, and that happened mainly with the stratification of cardiogenic shock by SCAI. So when SCAI stratified cardiogenic shock into 5 stages, A to E, say sometime in 2018, 2019, a lot of things followed suit. One could see that it was not just based on certain numbers, there were clinical signs, there were things that clearly delineated each stage of shock clinically, so that for the bedside clinician, staging the shock was easy. And based on the stage of shock, appropriate treatment could be given. And that forms the current cornerstone of cardiogenic shock management. So the basis for all this comes, as I said, from the SCAI classification. And the SCAI classification, if most of you know from the lectures that were done earlier on, has 5 stages, starting with A to E. SCAI has classified stage E as cardiac arrest. So essentially, the use of mechanical cardiac support devices in the various stages of cardiogenic shock usually starts from stage C. Stage D definitely would need some kind of MCS support. And in stage E, when your patient has arrested, one of the most time-tested MCS device that has shown some utility is ECMO, veno-arterial ECMO. And that's what I'm going to talk on today. Good. Right, while they sort this out. So, as I said, the use of veno-arterial ECMO in the context of CPR is something that's taking the ECMO world by storm. To be honest, the future of ECMO probably lies in ECPR. Centers are developing teams and organizing it the way it should be, so that the benefits from such an endeavor is maximum. And my talk today essentially is focusing on how this happens, how as ECMO center you can yearn to be an ECPR center, how you organize yourselves. And I think these are aspects that have or that need non-technical skills. So clearly, the masterclass today will focus on some of technical skills that are needed for ECPR, as well as these lectures which we talk about, and this Q&A sessions would address some of the non-technical skills which would be needed in the context of ECPR. So first and foremost, right. If you look at yourself as an ECMO center, how many of you run a full-fledged ECMO, what do you call it, full-fledged ECMO center? I mean, like, doing both VV and VA ECMOs. Can you please raise your hands? Right? Just one? None of you do ECMOs, is it? Right, okay. Good. Okay, then that gives me an idea of where we stand so that you understand this better. If you are embarking on a center that's going to offer ECMO to your patients, there are a few ways of doing it. Clearly, most of us start by offering ECMO to that patient who has severe respiratory failure, because we know outcomes with viral pneumonias are quite good, and 2/3 of these patients survive. So a lot of centers, when they start off, they predominantly start off as a respiratory ECMO center. There are few centers that develop as cardiac centers, and these centers would offer VA ECMO in the context of cardiogenic shock. Again, the organization is slightly different, but the basic principles of management of these patients are quite similar. And I'm sure in the last 3 to 4 days, whoever has attended the ELSO course, you would have gone through some of the basic tenets of how a VA ECMO runs and how a VV ECMO runs. So in the process of organization of an ECMO center, or if you're going to start an ECMO center, you probably would be looking for your first patient as that patient who has ARDS. Thank you. Can you change it back to the slide, please? It's really playing up. I initially thought I am more of a zombie. Yes, I am after my flight, but then this makes it more interesting. So coming back to where we were, so cardiac centers, respiratory centers, clearly, get developed when an ECMO center is being developed. So essentially, when you develop yourself as an ECMO center, you'll develop protocols for respiratory failure, you'll develop protocols for cardiac failure. A center that starts doing a fair amount of VA ECMO, arterial ECMO, as I said, you need a different skill set for that, will then start looking at offering ECMO in the context of CPR. So to get your basics right, your first case in your center, if you have just started, should not be that patient who has just had a cardiac arrest. You'll always be itching to go. There is always pressure from others to say that we have an ECMO machine, we have the circuit, we have a patient who is arrested, why don't we go on ECMO? And I think you should resist that temptation. Please don't do ECPR as your first case in your ECMO center. The main reason I'm saying is there is a learning curve to any kind of intervention. The learning curve comes by managing patients who otherwise have good prognosis. So such patients you get to see are those patients who have ARDS or respiratory failure. There is a learning curve there. And when centers start doing arterial ECMO for cardiogenic shock, they go through a different kind of learning phase, but it's much more than what you do with VV ECMO. Let's say you have done about 20 to 25 VA ECMOs in your center. You now have a working idea of how VA ECMO can be constituted. And it is in this background, or it is in this context, you should start thinking about offering ECMO for CPR where cardiac arrest has happened right under your nose. To put it in a different way, probably you are getting to that point where you can offer ECMO to in-house cardiac arrest, in-hospital cardiac arrest. So the way this thing okay? All right. Looks like I'm being tested today. Audio I mean, sorry, both visually as well as through the audio. Anyway, so if you have developed that expertise for going on VA ECMO with ease, then comes the next challenge where you do it in a patient where CPR is ongoing. So that's the kind of, you know, graded approach one should take when you're going to establish ECPR in your center. Don't rush into ECPR as your first case or in your first 20 cases. Till your center is good at doing veno-arterial ECMOs, please don't attempt ECPR at all. That's point number one. Now, once you start doing cardiac and respiratory ECMOs, clearly, you know, hospitals around you will start getting to know that you're doing ECMOs, so they will refer patients to you. You'll have to develop a transport team. Mind you, when you are developing your team to manage ECPR for in-hospital cardiac arrest, it's only a question of time before you get referrals for out-of-hospital cardiac arrest. So clearly, you know, once you're good at transport, then you start thinking about ECPR. ECPR involves being adept in both veno-arterial ECMO as well as sometimes even doing transports. Right? Now, I'll come to that part later, why I'm saying that. Let's talk more about ECPR. The best way to establish ECPR is by attempting it in a patient who has an in-hospital cardiac arrest. So that essentially means if you have a hospital setup where you have an ECMO setup up and running and you have reached that threshold, you would want to look at offering ECPR in the context of pediatric patients who have had cardiac surgery or adult patients who have either had a cardiac arrest in the cath lab, ED, or in your ICU. Again, you will find that if you even go by literature, the best outcomes for ECPR come from cardiothoracic intensive care units because, one, the chest is easily opened. Cardiac surgeons are best trained to cannulate in short notice. And clearly, you know, this reflects well on how the outcomes have been between, say, cardiac units versus non-cardiac units in the context of ECPR. I'm not trying to say that this should be practiced only in cardiac units. This is a skill which can be easily acquired, and provided you do enough volume of ECPR, you can reach those levels as well. So question is, you know, how are you going to select your patients? How are you getting to get to that volume of patients where you also maintain your skills? And again, last but not the least, you can think of ECPR in the context of in-hospital cardiac arrest, out-of-hospital cardiac arrest. Out-of-hospital cardiac arrest in the Indian context will have a lot of challenges. I'll talk about it. But at least, you know, for a start, if you're going to think about ECPR in a center where VA ECMO has been done many times, I think in-hospital cardiac arrest would be the first group of patients whom you should attempt it on. So ECPR as a concept was initially brought up in children. This was this is really playing up. Okay, that's better. Right. This concept was time tested in children as with ECMO all the time. ECMO, in fact, bloomed with the neonates and pediatrics. So was ECPR. This is a paper published way back, about 15 years back, where, again, this was a paper which I was alluding to, where outcomes after ECPR were better in cardiac intensive care units. Ravi and his team looked at the location of arrest and figured out that, you know, if this happens, say, in certain places, the outcomes are far better. And clearly, it made a big difference. So you'd be really proud about the fact that ECPR as a concept really bloomed from Asia. This was a paper published in 2008 from Taiwan. Yingshan Chen and his colleagues from Taiwan looked at comparing conventional CPR with extracorporeal CPR, and they had some interesting findings. Clearly, they did show some survival benefits. The best thing to note was the duration or the time taken to initiate ECMO under these circumstances. If the time taken was less than 30 minutes, about 40% of them survived using ECPR. As the time increased, clearly, this outcome was bad and different. Now that we have data from various other sources as well, we very well know that the best time to initiate ECPR is well within 40 minutes. If at all you're going to attempt, and for patient selection basis, most criteria would put it as trying to initiate ECMO within 60 minutes of cardiac arrest, right? So it's a question of how we are going to make this happen. You have those 60 minutes, the time ticks from the point where the heart arrests, and then you have a series of things to follow. If it is an in-hospital arrest, the series of things are a bit more easier. If it's an out-of-hospital cardiac arrest, you have pre-hospital things to do, you have few things to do in the hospital, and of course, both these group of patients will have a set of post-arrest interventions to do. But whatever said and done, unless and until ECMO is initiated within the first 60 minutes, ECPR outcomes are really bad. So here you have a time clock that ticks, and you are clearly, unless and until you are a robot or you work like a robot, you're not going to meet some of the ends. So clearly a challenge to the skills. It's people have mastered it in different ways. That's how I would put it, and hence the different models. And I think it's not difficult. It's just that you got to get it streamlined in your head properly. So we looked at essentially the outcomes from all trials, all studies, the propensity match studies, and we also figured out that clearly, ECPR is far better than conventional CPR. And clearly, this has now gone to the point that AHA is now put a stage 2A indication for ECPR. So going on to say that, class 2A indication for ECPR, going on to say that if it is in a setup where it can be initiated, international guidelines support and endorse ECPR that way. So if that is what it needs, then we need to figure out how we get equipped. Now, if you look at, this is in the broadest sense as to how things have happened. And now if you look at evidence behind ECPR, in the last 5 years, we've had 3 RCTs from 3 parts of the world. 3 of them did it totally differently. I will go through that again in the rest of the talks. And all 3 of them had 3 different outcomes. Going on to say that these trials don't tell us that only one system works. These trials also tell us what is not good in the context of ECPR. We'll dissect that so that we understand a lot more nuances of organization of an ECPR service. So paper published last week, and I suggest you guys go through this paper published in Lancet Respiratory Medicine. Group of experts who were part of the trials as well on how ideally an ECPR should be organized. So as I said, if it is for an out-of-hospital cardiac arrest, you have a pre-hospital phase, then you have a transport phase, then you have a specialized care, that is post-arrest care. And all these 3 phases need to be covered well if your outcomes have to be good. So if I have to simplify this whole exercise and tell you that ECPR can be effective only if these three parts work properly, so these are the major pit stops in the management of ECPR or in the setting up of ECPR. So if you are going to set up an ECPR program, if it is for out-of-hospital cardiac arrest, this part has to be covered well, otherwise your outcomes are going to be bad. If you're going to set this up for an in-hospital cardiac arrest, probably this will be taken care of because you're within the hospital. This part, these two parts would play an important role in setting up a proper ECPR program. Right? So we'll go into the details of it again, but then I just want to get the basics right here so that you understand that setting up or organization of an ECPR program is not that straightforward. You cannot equate ECPR to VA ECMO. That's the bottom line here. VA ECMO is a different modality, ECPR is a different beast altogether, right? The organization, the manpower, the resources, the cost, everything is different. So clearly, you know, please don't take it that if you are able to do VA ECMOs well, or if you are able to take care of such patients well, ECPR is going to be a cakewalk. No, it's not. So clearly, you know, this is one aspect I want to highlight as part of this talk. Again, as I said, please go through this paper, which they've illustrated it well. In fact, they've gone to the point that if outcomes have to be really good, we should have specialized ECPR centers where all cardiac arrest victims would eventually get admitted and they would be taken care of. So that's the crux of this whole paper, and it's very nicely written. So let's go through the 3 RCTs and let's learn from them what exactly was done so that we understand each of those pit stops well. The first RCT, this is not the first, isn't it? This was the last. So this was an RCT published by the Dutch about a couple of years back. They looked at ECPR in refractory out-of-hospital cardiac arrest. Now, if you look at the way this trial was organized, any center who is capable of doing ECMO were given rights to do ECPR also. So they were not high-volume ECPR centers. They were, say, you know, some of these centers did 1 or 2 ECPRs a year, right? So all these centers were merged together, and since they had the capacity to do ECMO, they were allowed to do ECPR as part of this trial, right? Now, what happened? Clearly, the survival with favorable neurological outcome, which is what you eventually look at, was just meager. There was no significance. So the moral of the story here is not that ECPR doesn't work, right? Because we always have this bad habit of looking at any JM through its abstract and its conclusion and concluding that this doesn't work. That's not the moral of the story. The moral of the story in this trial was the fact that in a pragmatic world, ECPR is best done in centers equipped to do it, rather than doing it in all centers. So this was one of the, so if you look at the editorial to this article, they would clearly mention that. And I think that's an important point you guys need to take home. The second trial, okay, now this, the previous trial had criteria quite similar to what most ECPR centers would follow. So age less than 65, witness cardiac arrest, and ECPR would be started they would offer ECPR if it can be started within 60 minutes of cardiac arrest. Then we have the Prague trial. Now, if you dissect this trial well, now, I'm not sure if any of you attended the Prague school of ECPR. The way they teach there, and if you look at the system in Prague, for any out-of-hospital cardiac arrest, as soon as the EMS gets the call, the ambulance services get the call, they reach the site within 8 minutes, right? The decision to go on ECMO, the candidacy, gets decided in the next 1 to 2 minutes. The total time to cannulate patients in Prague, so these patients are then, if it is decided that these patients are eligible candidates for ECMO, they are put on a thumper. And these patients are transported to the nearest emergency department with ECMO facilities. And such a transfer happens within 20 minutes. Patients are on ECMO in less than 40 minutes, say 40 to 50 minutes. Right? So the EMS, so this part comes here actually. So one, at the pre-hospital level, it gets quickly diagnosed, and there is bystander CPR. They make sure that it happens. And then the EMS makes the rest of the effort more memorable in that they do a quick job. It's possible in Prague, may not be replicable in other parts of the world. And once these patients reach, let's say, the hospital, and they are on ECMO already, they again go through a protocolized care. These patients then taken to the cath lab straight away. They undergo an angiogram. At the same time, they are cooled, and interventions happen. If PCI needs to be done, PCI gets done. Now, this is how this trial was done. Their survival rates were good. About 1/3 of these patients survived. But for practical purposes, the statistical methods they used showed that the survival was not significant. Now, I think we are all, focused on a p-value of less than 0.05 here. The point here is when these same group of authors did a Bayesian analysis, they figured out that this clearly works. And essentially, let's not go into the depth of statistics. At least we have evidence to say that if it is done in an organized way, it clearly works. So this is one model of care which a lot of people are trying to emulate so that their ECPR program is successful. So that's one model of care. Last but not the least, this was the first of the successful trials published in the Lancet that threw a lot of insights into how you do ECPR. Now, Dimitri in Minnesota, he's a cardiologist, interventional cardiologist, and he planned this trial in such a way that these patients get the best treatment when they have a cardiac arrest. I don't know whether yeah, no, that one. All right. So what he would do is, if there is a call from the EMS for an out-of-hospital cardiac arrest, Dimitri has a big Volvo truck that has every facility to initiate ECMO. So the truck reaches the patient where the arrest has happened. A quick assessment, again, takes less than, say, 20 minutes for all these things to happen. Patient gets transported into the Volvo truck, gets cannulated there. They go on ECMO, the patient goes back to the hospital. Again, same thing as what Prague guys did. A protocolized care thereafter. their success rates were one of the highest. 43% survival to hospital discharge. And this is what clearly, opened the eyes of many people on the utility of ECPR. In fact, this was one of the few trials which was stopped by the DSMB for a significant success in the interventional arm. So just because the trial had good success in the interventional arm, DSMB said, stop this trial, make this your practice. So if you have anybody in Minnesota, talk to them, or at least where this guy works. He has about 8 of these trucks that's traveling all around the city. There are 3 cardiologists who do round the clock this service. It's clearly tiring, but everything comes with an effort. He's able to show a 40% survival in this model. Again, going on to say that organized care, coordinated care that takes care of pre-hospital, transport, as well as post-arrest care is extremely important if you're going to set up an ECPR program. There's no point focusing on one aspect. You may be the best cannulator in town. You may be able to cannulate it in 5 minutes. Doesn't make a difference. And if these things are not properly organized, right? So it's an important lesson to learn. And this led to, if you look at other places as to how they have organized themselves, that this is offered in a coordinated way. This is how they do it in France. So France, Paris, Greater Paris, they have a ECPR team that cannulates on the scene. Clearly enough, the cardiac arrest happens, the team arrives there, decision to cannulate happens, and they cannulate on the scene. That's the subway in Paris, and that's the Louvre Museum, where ECMO cannulations have taken place. So again, if you're going to stick to this model, you're going to have more headaches, because a lot of medical jurisdictions may not allow such Samaritan help outside of a hospital. So you need your medical legal things sorted before you attempt on any of these things. Again, as I said, it's not just one aspect. It's a gambit of, or it's an umbrella of things that need to be done or coordinated if you're going to do it one way or the other. So now let's look at the challenges that we really face. So I've clearly, divided this into 3 phases, and each phase has its challenge. And unless and until you find your way of doing it in your backyard, I cannot say what is best for you, but at least I can tell you that these are the challenges you will face when you set it up. So you may find your own solution to it, then you will run a good program. That's the best way to do it. So what are the challenges? Well, clearly, the time to initiate ECMO is important. It needs to be as short as possible. There's no doubt about it. But it's not just that. It's not just that. It's something more than that. So if you're looking at the 2 broad models of ECPR delivery, you can either deliver it pre-hospital, or you can deliver it after transport to the hospital. So you either scoop and run, as the Prague guys did, or you stay and play, as the Minnesota guys do, or as the French guys do. So there are 2 broad approaches to this. So if you're going to set this up nicely, these are the 2 possible approaches that we need to adopt. Given the medical jurisdiction in India, I'm sure that we might be able to do it only in the hospital premises. So clearly, if you're going to work on it, you will need some tweakings to the rules and regulations. This definitely can be done, provided a lot of other things are coordinated. Now, when I say this, I'm sure you're going to argue with me, sir, this is how the traffic is in India. How are you going to get this done? Let me ask you a simple question the other way around. You are the guys who created the green corridor for organ transport. Am I right? Innovative. Nobody in the world does it. India does it. We've come out with some of the best jugaads in town. If that can be done, this can also be done. And if you think this is a big problem, and you cannot overcome that part of the pre-hospital care, I'm talking about Singapore. My problem is not horizontal, my problem is vertical. If somebody arrests in the 99th floor of a condominium, I just have 2 lifts which can approach this. So it takes more time, or as good as a time as you guys take on the road to reach to that person to offer ECPR. So clearly, everybody has problems in their backyard. We just need to think out of the box. Sometimes the out of the box solution might be something else, right? So the first point you need to understand is, you need to understand your landscape very well. You need to understand your landscape very well and then adopt anything between scoop and run versus stay and play. If that aspect is well sorted, then I'll tell you a few other things that can improve care. I'd like to share with you this model which is currently followed in Singapore. The Singapore system for cardiac arrest, once the activation goes, they follow what is called as the dispatch assist CPR. Now, what is happening there as part of this dispatch assist CPR is a few things. One, CPR education happens at the school level. So, my primary school daughters, they learn ABC. They have been taught to do CPR. And they know what, at least the basic things that need to be done when somebody collapses on the ground. Not just that, as part of CPR training, there are a lot of community programs that are held to teach people, especially people like taxi drivers, to do CPR immediately. And doesn't stop with the training. Any person who gets trained and certified as a BLS provider, his name gets incorporated into an app which he has to download. If there is a cardiac arrest happening, let's say within 10 minutes of the vicinity of this mobile app, the mobile app beeps. So there's a provider now, he knows where the arrest has happened. The app also gives the person an idea of where the nearest AED is. Every building has an AED attached to its basement, so the person knows where the AED is. So as a provider, there is a trained provider who can take the AED and offer CPR. So essentially, the bystander CPR rate after this program was established went up from a mere 20% to a staggering 60%. So clearly, if there was a cardiac arrest that happened on the road, people were not watching, taking videos and posting it on social media. They were rather acting, right? They were just doing what they were supposed to do to save a life. So that clearly, is something very important if you have to increase the rate of bystander CPR. I'm talking all this in the context of out-of-hospital cardiac arrest. So that's one thing which can be done. Again, it's a small country. Things can be organized easily. The magnitude is clearly different in India. But then, it's doable if we start practicing it in our own backyard. So clearly, only when you make the first step to changes happen. So that's clearly, one thing which you can learn as to how to increase the pre-hospital bystander CPR rates. Then the proposed model would essentially have a scheme for where you cannulate, how you cannulate, and what you do after you cannulate. For in-hospital cardiac arrest, this is easy. For out-of-hospital cardiac arrest, the proposed model would essentially look at something like a specialized center or a centralized ECMO center that would cater only to ECPR patients. So such a model clearly, is something which might work in the long run, especially when you're looking at not just recovery as an exit strategy. Patients with ECPR, only 25% make it. I have to be honest here. 25% of the patients who go on ECMO with CPR finally make it with proper neurology. The 75% of them, they die. And in fact, countries like Spain, Italy, parts of America, they are now embarking on these 75% of these patients who do not have good neurological outcomes with an exit strategy towards ECMO DCD or ECMO donation after cardiac death. So clearly, your exit strategy doesn't stop with patient recovery. An ECPR program should also look at, other viable exit options. Again, this all will need a lot of work with your jurisdiction and your brain death rules and organ donation rules. So people have already worked on it. There are countries that are already following it. So clearly, there is a room to emulate here. And as I said, people who reach the hospital on ECMO should have a proper coordinated care in terms of an angiogram, therapeutic hypothermia, and eventually post-op ICU care. So, and eventually, as I said, if the exit strategy doesn't, if it is not an exit strategy towards survival, you're looking at organ donation. Some of these patients might still recover, but their heart might not recover. So you might end up offering them advanced heart failure services. These are some of the papers that were published of late. I don't want to go there. So point I'm trying to make here is to have a successful ECPR program in your hospital, you clearly, if you're aiming for out-of-hospital cardiac arrest, you're looking at good pre-hospital care. If you're looking at in-hospital cardiac arrest, you need a team of trained doctors who can act immediately. We will talk more about how we attend to in-hospital cardiac arrest when you come to the stations. So I have a station on organization of your of an ECPR center for in-hospital cardiac arrest, and I'll talk more in detail as to how you make this happen within a short span of time. Again, it's not just the pre-hospital delivery of care. We need to have optimal transport systems so that these patients are transported to the nearest center for further care, and we need to build sustainable systems. It's probably good, but adoption should not be fast and furious. Yeah, you may have all these, big things like the Volvo truck or an Audi car that brings things to your footstep, but it's all about coordinated care that works. The process is more or less the same. As I said, it just boils down to 3 aspects of care. And if these 3 aspects of care are properly taken care of, you will definitely be able to deliver properly. So this is what I would conclude with. If you are, I just mentioned it as broad headings as pre-hospital factors, transport factors, and post-arrest factors. If you are looking into the nuances of it, each of this has more elements. So these are the pre-hospital. So if you look at the left side of it, this whole thing is pre-hospital care that needs to be optimized in a patient who has had a cardiac arrest. So you're looking at management protocols, public engagement, dispatch assistance, bystander CPR, hospital notification. All these things will have to be organized properly. If you're looking at just the hospital phase of care, you just have to make sure that you have enough volume, you have enough experience, and you have a training pathway that enables ECPR training. And of course, post-hospital phase of care, it's not just limited to longitudinal follow-up. There is some acute management that will be required. There are some protocolized ways of treating out-of-hospital cardiac arrest victims. And it doesn't end there with, it doesn't just look at survival as an endpoint. As I said, it can be recovery, organ donation, or end-of-life care. So clearly, this is how you dissect it to the finest points. If you're going to set it up properly, you're going to have each of this as a challenge when you set it up. I'll stop here and I'll take your questions. I'm sure you'll have a lot of questions to ask. I'm more than happy to answer your questions. Thank you. Yeah. Any questions?
Yeah, wonderful talk, sir. So, yeah, in India, the first criteria what we are looking at is bystander CPR, especially out of hospital. So, the public and even if I am a trained provider, it's going to be difficult for me to initiate CPR at the middle of the road or anywhere in the system on how the public is going to react. So, educating the lay people is more important, and I just happened to look that in the local railway station there's a AED available. So that is one thing which is making things more, awareness is more important. And of course, then we go to the ECPR part of it. It's still a long way, I think.
It is a long way, but I think we need to take baby steps. Can you give me the slides? Slides again. We need to take the baby steps. As you rightly said, AED in public places, rail stations, airports, it's an important big step. I think this just needs to extend to every apartment doorstep, or every apartment, on the basement, you should have an AED day. AEDs are not that costly, so clearly, it's affordable. If every, I'm sure we all live in places where we all pay a monthly fee, and this clearly can be got in close communities. So that's not difficult. It's education, and clearly, if you start educating the school children now, the next generation will be able to definitely do it properly. Because at 40 or 50, it's difficult to learn. You are stubborn. But this is, life and death. So clearly, awareness should be there. Any other questions? Yeah.
Yeah. So I have a question about Minnesota model you are talking about. Were there any hindrances within the US to propagate this model? Because
okay.
I have not heard of it.
Fantastic.
I worked there for quite a long time.
Yeah. Very good question. This model exists only in Minnesota, only in the state of Minneapolis. No other state could emulate it. That has been the biggest drawback of that model. And even within Minnesota, they are finding it difficult to sustain. I said 7 trucks, 3 cardiologists working around the clock to make this happen. It's not a joke. So clearly, I didn't highlight the challenges much so that, I just wanted you to know that such a model exists. But clearly, every model has its own drawbacks. This model exists only in Minnesota.
Morning. As you mentioned that the most important thing is the timing of, let's say, starting a CPR, transferring to the hospital, decision on whether to place on ECPR, and finally cannulation time. So in your setup in Singapore, how much time does it take on a mean if you're doing ECPR?
Good. I'll be honest here. We don't offer a full-fledged ECPR service yet. We've been doing ECMO for the past 30 years, 35 years. We select patients who would be offered such a care. And of late, in the last 2 years, we have now progressed to a level where we have primed circuits ready in cath labs, in my ICUs, so that at the earliest notice. So again, the way we went about it, I'll just give you so that you understand this better. A patient who have VF cardiac arrest, definitely they should be calling the ICU team, the ECMO team, within 5 minutes of cardiac arrest. Unlike other centers, which talk about even 15, 20 minutes, in hospital cardiac arrest, I'm talking about in hospital, they need to call us within 5 minutes of the cardiac arrest. So usually my calls come from cath labs, emergency departments, sometimes from the OT, sometimes from the ICU, right? So within 5 minutes, they get to me. The 2 important things I look for is, I ask them for an ABG, pH less than 7, Thank you very much. I don't offer them at all. Unless and until they are very young, say 30, 40 years, less than 40 years. But otherwise, no for ECPR. For patients who finally, qualify, during day hours or during daytime, during office hours, I can get this done in the next 30 to 40 minutes.
Okay. So regarding this, as you have correctly mentioned, maybe I was also thinking on the same lines. In India also, reaching to a hospital is very late. So in case if the unit is used to doing a number of ECMOs, maybe the place to start, as you are rightly doing, is in the cath lab or in the ICU or in the OR. Now my second query is regarding the candidacy. Do you have a tailored protocol for candidacy, as you told that if the pH is less than 7, you don't initiate?
Yeah.
Let's say. So do you have a written candidacy protocol in your setup?
So okay, there are two things that happens here. At least from a Singapore perspective, I have the Ministry of Health backing for my ECMO program. There is a nationalized ECMO program under the MOH, which does not endorse ECPR straight away, but only on a case-by-case basis. That essentially means institutions can have their own protocols if they want to initiate ECMO in cardiac arrest patients. My hospital, clearly, those patients who arrest in the cath lab, go on a thumper, they call me within 5 minutes, I definitely offer them. In terms of age, usually up to 50, 55 years, we do take patients. Younger patients, definitely we offer them. VF cardiac arrest, we definitely offer them. There is literature enough to say that you can offer it to PEA arrest as well. But for now, we offer it only to VF arrest patients. These are the two low-hanging fruits that you can use to screen. The third thing you need to assess is the ability of your team to cannulate within 40 to 50 minutes. So if the call comes at 2 a.m. in the morning, I'll be pragmatic. I know that my perfusionists are not on site. It takes 25 minutes for them to come over. Though we have a prime circuit which can be just pushed into the cath lab or elsewhere by my cardiac surgical residents, it still needs some amount of manpower to be organized at that part of the morning. So if your hospital has a shift system that can incorporate all this, then doing this at 2 a.m. in the morning might still work.
Yeah, we are also trying to get this in the cath lab primarily. We have a perfusionist all the time in the cath lab.
Mm-hmm.
So let's see.
Yeah, so I'll tell you what comes along with it. So if you have dedicated perfusionists just for the cath lab, it might be an overkill because cardiac arrest doesn't happen that often in the cath lab all the time. If you are going to take your perfusionist out of your cardiac surgical team, there will be a lot of whinging because clearly, there will be one man.
I manage both the ends, so it's okay.
Yeah, so as long as you are the boss and you'll be able to, get them sorted, it's the best thing to happen. Otherwise, your cardiac surgery will take a hit if perfusionists are borrowed from the OT. So that's something you will learn to manage sooner or later when you set up any ECMO program for that matter, not just ECPR.
Thank you, Doctor.
Yeah, first, can you hear me? First thing is that the AHA has had some guidelines on ECPR, and second is what are the current situation, current guidelines in Indian scenario for ECPR?
There are no, okay, let's start with AHA. AHA class 2A indication, as I said, for ECPR. So, if your center can offer it, they say it's very much within evidence to offer it. So, if this were to move to a class 1, we'll all be in trouble, because then you will be medico-legally impacted. For now, it's 2A, so we have a saving grace. If we are not offering ECPR, we may get scot-free. The second aspect is in the Indian scenario. There is no guideline on ECPR yet, to my knowledge, Pranay. Yeah, we are in the process of making it. Clearly, it's something which, given our landscape and background, the process of implementation might be different. So if you talk to somebody like Madan or Murali from Apollo, they have been doing it. So clearly, we may want to share how you do it in your center. But clearly, there are ways, institutions that are doing ECPR for select patients. But as a generalized guideline, generalized protocol, I don't think we have any. The only thing that has been published is from the ELSO guidelines. Do you want to share what you do with you?
Just as I said, Dr. Murali, I'm from MGM Healthcare in Chennai. We have a very active ECPR program that's now on for more than a decade, this one. But primarily to put the backdrop of it, we are a very active heart and lung transplant unit. So always patients are on ECMO. So just putting up the answers to the questions what came before in this. Perfusionists, a couple of them rather, are always there in the hospital 24/7, who are more focused on the ICU care, will support the OT also if required. Then coming to the guidelines, we still go with what is with the ELSO. We don't have any specific Indian guidelines, like sir said, probably we are in the making mode kind of thing. And we have the institutional protocol. The cases under our care, that's totally different. You know the patients who are waiting for an organ there, you know that, you know everything about them. When they're deteriorating or when come arrest, you immediately go and initiate that. Other than that, all the common areas where there is a possibility, like say ER, all the medical ICUs there, people know that, a team is there 24/7 available to do the ECPR. The moment it is an event, they immediately call us. And doesn't matter day or night, quickly go have a quick assessment. And whatever the primary team, they'll be continuing the CPR care there. Obviously, we go ahead and we do the ECMO. And once we do, we take it under our care. That's how it goes. Out of hospital, very few cases we have done. Not great results, but primarily, like what they said, this is where we are. This is where, even some VVIPs also, unfortunately, this part is not taken care. We're not come to a bystander CPR. A lot of times when they come to you, even you go ahead with things, you see that the quality of bystander CPR is very poor, which is reflected in the neurostatus subsequently.
So your lowest hanging fruit are those patients with in-hospital cardiac arrest for now. I don't want to make that as a blanket statement because there is scope. So for now, it's best done in in-hospital cardiac arrest patients.
Good morning, sir. What is the status if a patient is in arrest? So counseling part becomes a difficult task in Indian scenario.
Yeah.
You are going for assessment in 2-3 minutes, and that time the counseling should be done. The finances should be considered. So it should be patient should be offered ECPR on paper. If there is arrest, you are ready for ECPR or such kind of thing. Will it be a valid thing or should not be?
Yeah, tough one. Again, as I said, in the Indian scenario, the landscape is different, the approach is different. Clearly, consent plays a major part, and it's not going to be easy to get consent at short notice. But having said that, consenting for ECMO is a continuous process. It's not a one-stop consent where you talk about all this, do ECMO. Even when you talk to the patient relatives, nothing goes into their head. They would say, you do everything to save this patient. So clearly, it gets reiterated day after day. And clearly, that's an important thing. I'd just let Pranay or Venkat say how you consent such patients when they have arrested under your nose.
I think I discussed that yesterday. And we have been, so it's going to be mostly, again, as I told you, that we are doing more of an ISCA. So you know the patients, okay. Whatever few we have done, some of them where it was planned ECMO, and by the time we initiated, it has become an arrest. So it became an ECPR, okay. So again, out of hospital is going to be difficult till the time you don't get know the patient and that. And main thing is that you have to activate your management and administrative team, and they have to be in your loop so that there might be some losses in ECPR, so that they have to be ready to bear that, and they have to be actively involved. As far as that part is very important, because we cannot waste much of time in counseling for the finances, so that has to be taken over by someone else. You just to brief them and then let it be taken over by someone else.
See, you will get money when the patient is alive. So you have to invest some money to get more money. So don't take ECPR as a dead road at the end of the road. the management has to be wise enough to allow some finances to flow from the management, and the patient is alive, they will pay you 4 times. So therefore, and this program, after a ECPR, then if the patient may still be vegetable, there is a scope for organ transplant. And this becomes sort of a advertisement of your hospital that you are able to revive 1 patient out of 10 patients or something. So it is an investment. So if you are consenting for an ECPR and a emergency room, you just talk of the risk and start the procedure. If you talk of finances, you are going to waste time. There has to be preconditioning. The moment the CPR guys find that it will be difficult to revive the patient, within 5 minutes, he pre-activates or he gives the code alarm for activation of the ECPR. You have to be ready with everything. Even the patient has not consented, the relatives have not consented, and within 5 minutes the thing starts mobilizing. In 10 minutes of CPR, the consent should be coming regarding the seriousness. The relatives also see the criticality of the condition, and they also understand that the patient is on a split-second decision, so they will give the consent early if you don't talk too much about money. And you, as I said, you can cut down on a oxygenator and make your pre-primed circuit. It will cost you around 50,000 to 60,000 rupees only. So that much tolerance has to be there. Investment has to be there. To get more money, the patient is alive, they will pay you much more. So in ECPR, don't talk much about finances. Just say the management is going to help. Let us first revive the patient. Even if the patient is not survived, then also it is not a bad deal. Your team is getting experience, you are getting trained. And if 1 patient also survives, you will make up the losses.
Any other questions? Nothing else? Shall we get to hands-on then? Dirty our hands with a few skills to learn. Pranay, next is station system. Sure. Thank you.